I'm so excited. I'm sorry I'm not able to be there in person, but I'm just returning from traveling. So here I am on Zoom. But I'm really thrilled to be able to introduce Dr. Emily Lauer. Emily actually came to UMass in 2001, I believe, and has started out as I believe, a database manager with CEDAR, which is the Center for Developmental Disabilities and Evaluation and Research. And she has climbed the ranks to now be running the whole thing, which is quite impressive to say the least. In that time, she's also managed to get a master's and a PhD, and start a family, and do a number of other really impressive things. She's now an assistant professor here at UMass Chan as well, and is co-leading our USAID, which is another center, a large and incredibly important center grant that we also have through the Shriver Center. So as you can tell, she's become very accomplished over her years here at UMass. I would also say that she is a well-loved mentor to many people here at UMass and outside. She's quite a sought-after speaker all around the state and the country, and is known as an incredible partner when it comes to research and evaluation within UMass, and particularly at the state level. So I think we are so lucky to have her here. And finally, I would say, best of all, she's a phenomenal colleague. And if you don't work with her yet, I'm sorry for you, because she's fantastic to work with. You will tell from her talk that she is quite brilliant. She is also passionate, compassionate, kind, thoughtful, and has accomplished much, and will certainly accomplish more as she continues this work. So I'm very thrilled to get to introduce her, and I look forward to the opportunity to introduce her more in the future, because I'm sure she will be invited to many more talks.
Sarah Beth, thank you for what was a very lovely introduction in your kind words. So it's my pleasure to talk with you all today. My talk will focus on two areas: social determinants of health, how that affects people with developmental disabilities, in particular children, and how that relates to mental and behavioral health outcomes. I have no disclosures. So there's a limited literature on outcomes for children with developmental disabilities. What we do know is that they have a greater exposure to certain social factors that have the potential to affect their health. We're going to call these social determinants of health today, or SDOH. We know that they do have poorer health outcomes than their peers that don't have disabilities. There's existing evidence to support that certain SDOH, or social determinants, are at an increased prevalence. So we know about poverty, we know about victimization of abuse, but there's a lot that we don't know. And so we understand that these children may be at higher risk of adverse outcomes, also because of their interdependence on other people and social supports for their needs and their health. We can hypothesize from what we know in the literature that they may be more susceptible to exposure to adverse social determinants. They may have lower resilience-related skills and resources to combat those exposures, and they may have greater and more pervasive effects from these determinants. And this increased dependence is an additional risk factor, so they're relying on systems of care more than other children may be. Some of the recent studies have suggested that as much as 20 to 50% of their poor or mental or physical health outcomes could be related to their exposure to social determinants. So that's why I chose to understand this in much more depth. The literature on children with disabilities in the US related to social determinants is really, really sparse. There's been much more work done in the UK on this topic, but there has not been a sweeping understanding of how they're exposed to determinants, what happens when those exposures happen, and whether they can mitigate those exposures. And so the literature that does exist is really focused on very isolated factors. So they look at one determinant at a time. They might look at what happens for children in poverty and not in poverty, or who have in-home challenges or don't. But they don't look at how the factors happen in real life. So you might be living in poverty, but you might also experience challenges at home, and you might have challenges in your neighborhood. So you don't generally just have one determinant that you're living with, you have multiple on different levels. And the studies to date haven't done a good job of taking all of that into account. So my approach here was to try to actually model some of these determinants, their exposures and their outcomes as they're lived. So at different levels at the same time. And to do this, we needed to understand determinants at many different levels, and I'll walk through how we broke those out. So first, I looked at whether children were exposed to these determinants alone and in combination, and whether that was different for children with developmental disabilities or not. I also looked at whether children with developmental disabilities were particularly susceptible to altered health outcomes. So I looked at some mental health outcomes and behavioral health outcomes when they were exposed to these determinants. And then I looked at a range of resilience factors, and I wanted to know if children who had these resilience factors were able to mitigate the effects of being exposed to things like poverty or in-home violence, and whether they had the same outcomes in mental and behavioral health as the children who didn't have those resilience factors. So what these three steps I think will do, and I'll show you the results today, provide a more complete and a contextualized picture. So we're not just looking at one factor alone. We're able to understand how these factors interact and how they are related to outcomes. My hope in doing this is to be able to inform public policy, public health, medical care, and social related health service systems, because I don't think we have the evidence we need to direct effective mechanisms to impact these associations. So to be clear about what I'm talking about with developmental disabilities, this is a group of conditions that present in the developmental period, so typically before 21 years. And they can impair physical, intellectual, emotional, and behavioral areas. And they really impact things like executive function. So the child's ability to navigate their environment, to do things independently, to learn, to care for themselves, and to function in some of our social systems like a school. For social determinants, I broke the determinants down into three different areas. So there's structural, those are the bigger systems that might interact, like poverty, social economic status. Intermediary is things like neighborhoods, schools. So they're not exactly in your home daily environment, but you go through them, you interact with them frequently. And then we have proximal, which are much closer to your family. And these are things like the health of your parents and how skilled they are at parenting, what the lifestyle is like in your home, the level of engagement, whether there's violence or other risks that you might be exposed to. For resiliency factors, I looked at a wide array of these. So how closely your family has cohesion. Do they work together to solve problems? Do they have good parenting relationships with their children? Do the children have good coping skills and other social resources that might buffer the effects of social determinants? Importantly here, I also looked at financial and disability services. A lot of the times other studies do not look at the receipt of these services. And there's a very interesting finding I want to show you later about the school-related services. So from the literature, we know certain things about social determinants of health. We understand that racism and white privilege also intersect with disabilities. So disabilities, there's intersectionality in that if you have a disability and you are also a racial or ethnic minority, you have multiplicative effects of having both of those things. We also know that children with developmental disabilities are more likely to be poor, remain poor, and struggle to get out of poverty over their lifetime. So it's a longitudinal burden. And we know that children in particular are susceptible to the determinants in their homes. So if they're faced with this every day, they're faced with this in their homes, those determinants tend to be the ones that drive the most adverse outcomes for them. We also looked at toxic stress from adverse childhood experiences. So we understand that if you have multiple adverse childhood experiences and repeated adverse experiences in childhood, you're more likely to have stress buildup that affects your physical and mental health. In short, these exposures to social determinants of health that are adverse can have lifelong implications, and that's why we want to look at them in childhood. So I had 3 research questions that I examined here about whether children with developmental disabilities have greater odds of exposure to these determinants, whether there's a relationship between these determinants and child and behavioral health outcomes, and whether this relationship is modified by family resilience factors. And my hypothesis here is that children with developmental disabilities have more exposure, they are more susceptible, and they experience less resilience. To do this, I used the redesigned National Survey of Children's Health. This survey previously was focused on children and children with special healthcare needs, but it asks a lot of really interesting questions that get at much of what I was seeking to study. That survey has been redesigned and combined, and children with developmental disabilities, because they have special healthcare needs, are oversampled. So it allows me to study what is a minority population with much greater strength, and I could combine a couple of years of the survey to give me enough power to do an examination of multiple factors at the same time. So it's a really well-designed survey and allowed me to get at some of these questions in a way most other surveys of children do not. I looked at children aged 6 to 17 years, and I did this because the earlier period can be a time where you're sorting out diagnoses or they might be emerging, and so it can be a little murkier to understand whether a child has a delay or an actual disability. This is a survey of US household residents, so that is one limitation. We can't look at children who live outside of these households. And I formed a subgroup of children who have developmental disabilities, inclusive of things like intellectual disability, autism, moderate or severe cerebral palsy, and Down syndrome. And then I have a comparison group of children who do not have a diagnosis of these conditions. My first research question, again, I'm looking at the exposure to social determinants. I used logistic regressions to account for our survey design effects. And I first examined each determinant on its own, and then I looked at them in combination. So these are some of the determinants I was able to examine in the survey. On the structural level, we have things like poverty, and including low income and hardship, health insurance status, a variety of neighborhood factors, both positive and negative, housing, food availability. And then within the family, these are the proximal determinants, so things like adult employment and health, the resources of the parent, a whole series of adverse childhood experiences, which forms a scale that I'll talk about in a minute, and some in-home stimulation about the amount of screen time children get. The results here were that we had about almost 7% of the children in the survey had a developmental disability, and they either had a similar or higher exposure to almost every social determinant I looked for. So the burden of exposure was really high. In structural factors, we saw that they were more likely to experience hardship and to have low income. They lived more often in poor neighborhoods, had poor housing, had more food instability. And within the home environment, they had a lot of differences and a lot of increased odds of adverse exposure. So things like poor physical or mental health in the family and the parents, lack of employment, more screen time, and the parents were stressed. They had challenges handling day-to-day demands. They found their children harder to care for than most other children their age. And they found some of the things their children did more bothersome, or they had more anger toward their child. So I'm seeing signs that these are stressed parent-child relationships. For the adverse childhood experiences, children with developmental disabilities had much greater odds of experiencing almost every type of ACE that we looked at. The most frequent were being bullied, picked on, excluded by other children, having split parents or guardians, and having substance abuse or mental illness in the home. So I confirmed my hypothesis here about the extent of exposure, although I will say it was even more than I was expecting. What we see is social determinants in the lives of children with developmental disabilities across multiple levels. And what we know about this is that makes them much more durable. So it's the fact that they exist in almost every environment they're interacting with means they're sustaining, they're hard to mitigate. If you poke at one, it's hard to get rid of the others too. And we know that this means that they're at lifelong risk of some of the challenges that we're concerned about. It also confirms some findings that were done in the UK and other studies about the stratification they experience socially. And interestingly, parents and families at similar income levels, if they had a child with a developmental disability, had greater income hardship. And we think that's because of the costs of caring for children with developmental disabilities, financially and otherwise. So we see that there are gaps in resources here that would contribute to the family's health and well-being, like education level, employment, parent health. As I said, we also saw evidence of poor family interactions. So we're seeing that while we can't exactly inform temporality, some of the questions do ask about proximal time. So we're able to understand that there is stress here, and we don't know if it's because some of these determinants are adding stress and that's sort of spiraling, or the stress started and then it made mental health worse, for example. So that's something to definitely tease out in further research. We do know that the school environment is a potential source of resiliency for children. It can be a positive experience. It can be a source of services and supports. But what we're seeing for children with developmental disabilities is they're more likely to experience negative effects in school. So being excluded, being bullied, and not feeling safe. And so that raises some concerns about whether school is a source of resiliency for these children. For the second research question, I looked at mental and behavioral health outcomes. So I looked at a combination of moderate and severe depression and moderate and severe anxiety. So I asked, did they have this level of depression? Did they have this level of anxiety? And did they have both? I also looked at moderate or severe attention deficit disorder and reported behavior problems in school or at home. I used similar methods using regression to look at different exposures and different relationships, and then looked at them in combination. And so what I found is that children with developmental disabilities were much more likely to have all of the behavioral health and mental health conditions I just looked at. They were much more likely to have behavior problems, and the rate of attention deficit disorder was really high, as I'll show you. We also saw more anxiety, more depression, and more anxiety and depression together in these children. In children that don't have developmental disabilities, you tend to see a difference by sex. So females have certain types of depression more than you would see in males, for example. We didn't see that in children with developmental disabilities. It was very even across the sex. So for anxiety and depression, we saw an age-related effect here, that this anxiety and depression, the odds of it was much greater in the teen years. So once you hit about 13, you can see that the odds go up substantially. And we found that social determinants that particularly were related to this anxiety and depression were being unsafe at school or feeling unsafe at school, having adults in the home with a mental or emotional health problem, and some of this parent-child interaction as well. Interestingly, though, all of the structural determinants, so poverty and things like that, fell out of the model when we looked at all the determinants together. So what that tells me is it's not just the fact that you live in poverty that determines whether you're anxious or you have severe depression, that these other factors do a better job of explaining which children do and do not have these conditions. And really what we saw is it's the home environment and their daily interactions and experiences that tends to contribute most to whether they experience moderate or severe anxiety or depression. So I think this leads us to a couple of strategies. I think early screening and service availability to try to catch these things before they're in the moderate or severe stage, or before they're in the teenage years. And also strategies to support parents to manage their own mental health and to have stronger connections with their kids are takeaways from what I'm seeing here. And I think the awareness that both male and female children with developmental disabilities are at risk for these outcomes is important. So the poor parent-child interaction, as I mentioned, can go in a couple different directions. We know that having a poor relationship can stress that even further. We know that early stages of that can contribute to other outcomes. So I'd consider this bidirectional. This is a cross-sectional survey, so I couldn't go any deeper in the data that I had, but I do think it's an area for further study and understanding. We also know from other literature that parenting skills and their resiliency and how they interact with their children are somewhat modifiable. So these seem to be an early target for how would we stabilize that home environment and try to protect against the negative outcomes. What we see also is, I thought when I looked at whether a parent said my child is safe at school versus whether they're being bullied or excluded, I thought those would be measuring the same things. And so I was really careful about not putting them both in my model until I examined that. But what I found is they actually are measuring distinct things. And so what that leads me to believe is that potentially the reason children don't feel safe at school has to do with their relationships with adults, not peers. And I also think that's a target for modification, that if they have stronger relationships with the adults in their lives at school, that they may have some protection against these outcomes. ADHD, I think, requires a little bit further study. I saw a really increased odds, so more than five times the amount of ADHD in children with developmental disabilities versus not. And I think there's some challenges in diagnosing that and whether that's an accurate diagnosis. So I'm taking these findings with a bit of a grain of salt. But we do see some social ostracization here, that the children who are bullied and picked on and excluded by other children are more likely to be the ones that have ADHD. And there are some in-home conditions like the health of the parent that also affect that. There are some race and ethnic effects here as well. So I don't know if the increased prevalence of ADHD here is due to diagnosis clarity. I don't know if it's due to shared neurological etiology. There's a lot to unpack there. So I don't know if it's true or not, or whether it's an artifact of other things. I did see that living in a poor neighborhood was associated with a lower risk of having ADHD. I don't think that's true. I think you are less likely to be diagnosed with ADHD. So I think some of these findings are actually a proxy for access to healthcare, access to diagnoses, not the prevalence, the true prevalence of these conditions underneath. But I do think that the social ostracization is important to look at because it can be bidirectional. So if you have the behaviors associated with ADHD, your peers might be more likely to exclude you. But being excluded might drive up your perceived negative behaviors because you're trying to communicate that you're uncomfortable with that and maybe you don't have the skills. So I don't know that it's one is necessarily coming before the other. I think they're intertwined, and I think they can make each other worse as they go over time. When I look at adverse behavior, I also saw an age-related effect, but in the opposite direction now. So younger children were more likely to be reported to have adverse behaviors in the home and in school. Once they hit about 14, that started to become less significant. So we're talking mostly about the younger children here. Again, we saw a strong association with having a developmental disability and the likelihood of having adverse behaviors reported by parents or by the school. We saw effects or associations with determinants of health across all three levels here. And so we did see some in-school pieces around being bullied or picked on or excluded, but we saw things in the household like low food availability, having unmarried parents, and some smaller effects that also were in the home environment. So while the developmental disability was a strong effect of adverse behavior, when I looked at it alone, it had an even stronger effect. So when I brought the determinants into the model, that helped explain some of the differences more. And so what I'm seeing here is that it's not just having a developmental disability that means you have adverse behaviors. It's also the increased exposure that you have to these determinants that affects whether that behavior is perceived as adverse. So I think that if we address some of the determinant exposure, we may be able to address some of the behavioral patterns. Like ADHD, there is a relationship with being excluded and bullied, and that might be bidirectional. But going back to the school as a positive source of support, I think it is something that can mitigate some of these home exposures. We've seen food programs, right? So if you have low food availability in your home, you might be able to get more of that at school. And the risk here is that school is also a challenging environment for these kids. And I think that there's more work to be done there. I think screening of risk in the homes early, especially for young children, is important to try to get ahead of these determinants and minimize their effects. And if we can stabilize those home environments more, I think there's a likelihood of better outcomes. I think this also plays on some of what we saw earlier about parents needing greater supports, educational programs, strategies, and making sure that they have a strong child relationship and that their home environment is strong. The association with the adverse childhood experiences means I think we need to be really sensitive to provide trauma-informed care and understand where trauma exists, because these children have evidence that they are exposed to more trauma-inducing events in their lives. And I think that looking at the primary drivers of caregiver strain is important in order to make sure that we're able to intervene early, but also in a way that makes sure that the strain doesn't get worse over time as these children age into adulthood. For my third research question, I looked at the resiliency factors. So I wanted to know, of the effects that I found, if I start to look at who has things like coping skills or strong family cohesion, does that matter in terms of which of the children have these mental and behavioral outcomes or not? And there's a whole set of these factors in the survey that I used. So I used factor analysis to group them and inform where they were measuring similar constructs. So I took my multivariable models, my logistic regressions, and I introduced these terms and I looked at how it modified the relationships and associations that I was seeing. So for the results here, I found that while I looked at the resiliency factors in isolation one by one, they did have significant associations with the mental and behavioral health outcomes. But few of them really had any significant protective association when I looked at them in combination with the social determinants. So I think that means a couple of things. I think there is some small potential effect from these, but I think the determinants in terms of the amount of determinants and across all the different levels are swamping the resiliency factor's ability to mitigate the outcome. And I think that means that these are fairly durable exposures, that they have lasting effects, and that the resiliency factors essentially aren't enough to get over the hump of what that exposure does. When I looked at anxiety and depression, I found that only the parent-child connectedness of all the factors I looked at, continued to have a significant association. And that was only true for children without developmental disabilities. So even that wasn't quite enough to overcome the factors that were associated with anxiety and depression for children with developmental disabilities. For adverse behaviors, I found a parent rating of positive child temperament was highly associated with being protected. I think there might be a little bit of confounding here, because I think part of who you're going to label as having a positive temperament as a child is a child who's not having a lot of adverse behaviors, right? So I think they're measuring a little bit of the same construct. But within here, there are some important pieces about whether they're able to move through tasks without getting frustrated, whether they're able to complete some of their schoolwork and do other things in their lives. So I don't think they're exactly the same, but I do think they have some relation here. Parent-child connectedness continued to have a really strong association. So the stronger that connectedness was, the less likely the child was to have adverse behaviors. Again, it could be that there is some stressor here, that those adverse behaviors cause a degradation in the parent-child connectedness or vice versa. So that's something that I think takes some further work. So when I looked at special education and developmental services in the school, I found something really that I wasn't expecting. And that is that when we look at anxiety and depression, if you're a child that doesn't have a developmental disability, you follow a pattern that I would expect. So the more anxiety, the more depression you have, the more likely you are to have a developmental service plan or special education plan. You're more likely to get services for mental health in your school. But if you have a developmental disability, the more anxiety and depression you have, the less likely you are to have a plan in that school. And I looked at this a few different ways because I first thought it was a mistake. It's an inverse dose dependent relationship. And when I dug into this further, I said, okay, there's a varied group that I have in developmental disabilities. Is it particular subgroups? And it was. So it's really children with autism, severe cerebral palsy, that are experiencing this lack of services when they have really severe anxiety or depression or both. And I suspect these are children who might not outwardly appear to have such substantial disabilities, who might be able to express themselves more verbally or the school doesn't exactly know what to do with them as much. So I think they're falling through the cracks. And I think it's concerning because I restricted anxiety and depression only to moderate or severe, so that I wasn't getting kids who occasionally had anxious behavior, but were labeled as having an anxiety disorder. These are the kids at the end of the spectrum who are having this daily, basically, or very, very often. So these are the kids who need these services the most in the schools, and they're less likely to get them than their peers among the group that has developmental disabilities. This wasn't true for children who have Down syndrome and some of the other identified etiologies. So this really seems like a big target in the school systems to understand why this is happening and try to fix this as a short-term solution to increasing the welfare for these children. We do know that special education services requires some skilled advocacy. So I think there's also some interconnectedness here, that if you're a parent who does not have a great health status, who may be struggling with other things, maybe struggling with poverty or trying to hold on to a job, or may not have the skills and ability to advocate well, you're less likely to be effective for your children. So there's also a multiplicative impact here when you have these home environment stressors about what's going to come into the school environment, because that parent advocacy is really important. And so unpacking all of this and starting to make sure that children with developmental disabilities had the advocacy and supports, I think is going to be one of the challenges of the future and a challenge now. So overall, just in summary of some of the findings here, I found that children with developmental disabilities had fewer resilience resources overall in every place I looked, except for some of the service receipt. We see a double burden, really, that those who are facing the most adversity have the least resources to build resilience and to get out of that. And that also increases the likelihood that it's going to be a lifelong effect for these children. And as I mentioned, I do think that there's a really, what I'm calling a durable impact from social determinants, such that there's complexity between different levels of interaction and institutional factors. There's multiple resource gaps. And so it's going to take an array of strategies to try to raise up this population. So overall here, I did contribute, I think, to the literature in that there's never been a study in this population, children with developmental disabilities, that's looked at all these factors or on all these different levels. And I think there were some really clear targets that emerged out of this work for next steps in policy and practice. And I was able to confirm all of the hypotheses that I had about the increased exposure, increased risk of adverse outcomes, and lower resiliency. And so I do think this provides evidence to needing to impact these exposures and their effects in childhood before they have a greater experience of adversity over the lifelong trajectory. Clearly, we saw some disparities in school-based supports, and this inverse dose-dependent relationship I found particularly concerning related to the plans and services, because that is where I would expect those children to get most of their services, especially if they don't have the financial means to get them out in the community and other locations. We saw really pervasive effects of social isolation for children with developmental disabilities. And there is some other literature that there are strategies that the school can do to increase that modeling of behavior, of inclusion, and other strategies. And I think that there's more to be done to try to make sure that these children aren't as isolated from their peers, because I think that is connected to some of their adverse outcomes here, at least by association. And I think we found some key child and family level factors to try to build up to introduce more resilience and more stability. This study, I pushed this data really far. It has some limitations. It is cross-sectional data. Some of the questions, as I mentioned, do have an aspect of temporality, so we're able to understand roughly when some of the things like diagnoses, onset, or some of the conditions, but it's not a longitudinal study. And so I can't say, a child was exposed and then this was the outcome directly. And so that is one major limitation. I was limited to the variables that were in this study and how they were constructed. I do think it was a well-designed survey that had a lot of the resources and things I was looking to measure, but there may be some other factors that I would have wanted to look at that were not in here. This survey is done on parent report, and so I don't have the voices of the children. And I think for some factors like, do you feel safe at school? I would want to hear that from the child. And there's some places where I ideally would want to hear that, but this survey did not allow us to look at that. And I suspect that there are some children who have even more exposures and even more risks because they're not living in US households. So they're institutionalized, they're homeless, they're moving between locations and wouldn't ever really get in this survey practically. I was not able to study those children. And I think that I would imagine everything I found here could be even greater for that population if I were able to include them. And there are some areas where I would have wanted to untangle the effects or interactions even more than I was able to do. And the variables didn't allow me to do that to this extent. But I do think this was a rich survey that gave a lot of different insights. So there are some recommendations I have for future research that I want to talk about. First and foremost, I think that for social determinants of health in the US, at least, we're not really prepared to measure them well. There's a lot of practical challenges about screening children for these, but we don't have good screening tools. We don't have a lot of evidence-based, validated tools to measure this in children. So when we say we want to understand these risks earlier, we don't always have a good way to do that. And so then we miss sometimes the rest of the story or the ability to intervene. So because I think we're underprepared, I think the first area which would benefit children with developmental disabilities and all children would be to fix that, to be able to screen and have better tools there. And I think that, this is really fertile ground to move forward in how we think about and handle social determinants. We, as I mentioned, are a little bit behind some of the other countries in Europe and others understanding these effects and actually trying to do more about them. I raised that I found the ADHD findings a little messy. I think there's more work to be done here to understand the actual prevalence of ADHD in children with developmental disabilities and where that's present and where it's not. There are some areas of bidirectional relationships that we found between the determinants and outcomes that I think need to be unpacked and not in a cross-sectional survey. And we need to understand the factors that are driving this gap in service receipt in schools and try to fix that. But I don't like to end just on further research because I think every talk has further research that we can do. So much of my work in the Shriver Center is very policy and action driven and services, delivered today. So while future research is really, really important, I think the next action steps are just as important. So the first thing I would say is, given the burden that we saw, we want to be careful not to create policies and services that increase that risk. And I think that's a real risk. I think that that's a spot for knowledge and advocacy to the decision makers in those areas. But I do think that there are changes that could come. I think the pandemic changes in some cases, we saw real evidence of that it's not that hard to make this even more risky for the children with developmental disabilities. So we want to take a really careful approach to that and be thinking through the effects before we put those changes in place. I think there are opportunities to have better social policies that look at trying to reduce the inequities that were experienced here for children with developmental disabilities, and that would have some impact on the outcomes that I studied here in mental and behavioral health. As I mentioned, the screening for social determinants is really important. I think the more we can do to do a really good job of that, but have ready responses. Sometimes we screen for these because we understand their importance, but then we don't know what to do next. And the entity that is screening, I've found, isn't always the entity that can act. So a pediatrician might screen you, but they can't necessarily fix all your social problems or issues your parents are having or those kinds of things. So how do you connect that family to the next step? So if you are the screener, if you're the person asking the questions, and you can't act on what you're finding, how do you ensure there is someone or there is a resource that can? And as you saw, there were a variable amount of things I looked at in terms of exposures. There's not, I don't think, one entity that it can impact them all. So where you go from the screening to actually mitigating that is challenging. And I think we don't have a good network for that. We're just starting in some other areas, I think, and we need to build that up if we're going to be very effective about addressing the things we're screening for. I think there are early targets to act on related to the social isolation and parenting skills and the relationship with the children here. I think making sure there's better supports in schools for mental and behavioral health and that they understand how to work with children with developmental disabilities would be important. I think my theory from the gap we saw in schools and all the work the Shriver Center does around that is really that there is a lack of understanding of what to do, for example, with the children with autism who have adverse behaviors, may have anxiety. How do you produce the right supports for that child? And this is where I think some skill building and training for professionals would be helpful in the school systems, but probably also out in the communities. I mean, we see a lot of challenges in access to professionals, mental and behavioral health professionals who know how to work with this population. There certainly are some specialties that are trained for this population, but there aren't enough of them to deal with demand. And so I don't think the resources are fully there to address and employ evidence-based strategies as needed. And I think the more we can act to improve access to services and supports, both for these children, but their families, will kind of raise up the whole unit. And we know that these children are more reliant on the services and supports and systems around them. And so the more we can mitigate stressors for that entire family, the more we're going to help the child and the rest of that family unit. Great. So I'm going to pause here to see if anyone has questions or comments.
I have some questions online. Does anybody in the room have a question? Hold it. Hold it. They can't. The Zoom people can't hear you. That's the purpose of this.
Hi, thank you so much. I really enjoyed this presentation, and I'm thinking about the parent stress and parent-child relationship outcomes and relations that you saw, which is so important. And I'm thinking, like you were talking about better connecting families and kids to services, and how like these parents understandably are really like burnt out and tired and frustrated and angry. And getting into services can be such a challenge in and of itself. So I was curious if you have ideas on kind of like helping smooth that pathway for parents who are already burnt out and their kids are especially needing those services, especially if those kids do have the co-occurring disorders like depression and anxiety and are getting missed at school. And then it falls back on these parents who are, it just seems like such a tough cycle. And I was curious about your thoughts on intervention there.
I think this is an opportunity for what I would call a skilled navigator. So I think what's challenging, and part of my background's in sociology, so the institutions, like how do you get through the barrier of getting to services, whether that's medical services or advocate at the school, or there's all these like hoops and barriers that are in place that leave people out. And I think if that family unit could latch on to someone who knew how to handle those systems and get through them and could guide the family and support them in doing that, I think you'd see a lot more success. Because sometimes when those parents are coming and they're at the point of, I can't work because this is happening. I'm stressed about money. My health's not great. I don't know what to do at home. Their ability to navigate that, even if it was great back here or decent back here, it's not so good now. So if we can have, and this is really hard to pay for right now in our financial models, and I think that's one of the bigger challenges. We see models like autism care navigators and other things. They can be really effective, but often that's, if a clinic has it, it's philanthropy that supports that. If a parent wants skilled advocacy in a school, they have to pay out of pocket for someone who's a consultant. There's not a good set of resources that meets that family where they're at and says, okay, what do you have? What do you need? How do we get you there? And I think that is something that could be trained. I think there's a potential for a workforce for this, but right now I don't see fiscally where is that coming from? The schools don't seem to have or dedicate the resources, and I'm not being critical. It's not really built into their model, but where does that live? I think is my big question from a systems standpoint, because I think that is one of the more promising solutions.
Thank you.
Yeah, thanks for your question.
So, Dr. Carol Curtin, hang on, she moved. She says, great talk, Emily, lots to unpack here. Were you able to determine whether kids were getting any services and or treatment outside of school? You may not have looked at that, but it would be helpful to know whether the outcomes differ by receiving services or help in some manner.
That is a great question and good point. I was not able to cleanly look at that. I do think, though, there's a interaction between poverty and the ability to access those resources. So children with developmental disabilities, I looked at another research question around health insurance and access. They were much more likely to have health insurance. And I think that that's through Medicaid and the ACA. So their likelihood to get services, if they can find a provider that takes Medicaid, then they may have an increased ability to access the services. But if it's self-pay or they can't find a provider that takes their insurance, they may have a decreased risk. So I don't know if community-based resources outside the school are supplementing that gap. But even if they were, I would expect those children to still have special education plans. So if they're being treated by a professional in the community, there's an opportunity to advocate and have that professional write letters to get a special education plan. The fact that there's no plan makes me concerned that there may not be much of that other support outside the school system too. So, Dr. Curtin, I was not able to directly answer your question, but that's my working theory about where that may head directionally.
We have another question from Dr. Rangsung Sidichai. Great talk. Do you have screening tools to highlight the individual, family, or community strengths or the resilient factors?
There are some screening tools about the neighborhood factors. I cannot speak to their strength. When I looked at them in this survey, there were some confusing findings, and some of them didn't actually seem to be related to any of these outcomes. So I'm not sure that they are screening for the right things. Some of them are like, is there graffiti in your neighborhood? I don't know that that's the best measure of risk in your neighborhood, and it's broader than that, but there are tools. I can't speak to how good they are. And then I think with the resiliency factors, I looked at a lot of different resiliency factors. I am not aware of a tool that goes down all of these. There may be tools that exist within some of these factors, and even some of the questions that were on this survey I think have merit as a screener, talking about family cohesion. And they walk into questions like, what is it like when your family is dealing with a problem? Do they work together? Do they do these other things? I could see that being a screening question. And of course, it's validated on this survey. So I think that there's pockets of things that could be used, but I don't think that there's enough valid screening across these factors to do a good job of looking at all the potential resiliency factors.
Any other questions? All right. Well, thank you very much. It was very interesting. Thank you.
Thank you for having me.